Now we come to the last plenary lecture and the last event in this day. And it will be presented by Oliver Glenn from France. Will be presented by Oliver Glenn from France about curative and preventive treatment of peritoneal metastasis from gastric cancer.
Thank you very much. Thank you again for your welcome invitation. And it's a privilege for me to conclude this very nice and beautiful Congress. So we will speak about a controversial topic, the curative and the preventive treatment of peritoneal metastasis from gastric origin. This is the survival of all the patients that were treated in Lyon Sud for peritoneal surface malignancy. And you can see that the lower curve in terms of survival is for gastric peritoneal metastasis. But you can see also that we had, for some proportion of patients, long-term survival with survival at 10 years. When you look at the different meta-analyses that evaluated the benefit of intraperitoneal chemotherapy in combination to surgery, you can see that for the treatment of peritoneal metastasis from gastric cancer, we found a strong and statistical benefit, especially when intraperitoneal chemotherapy is combined with heat. But first question, is it possible to cure patients with a gastric peritoneal metastasis? This is the question we asked into our French registry, and we selected patients that were treated only with a curative intent, so with a complete or a subcomplete macroscopic resection, and we looked if some patients had 5 years survival without any event, without any recurrence, and without any therapeutic treatment. And we found that 10% of patients that were strictly selected could be considered as cured. They were all synchronous disease. They had all a very limited disease. They were all treated with complete cytoreductive surgery. And you can see that some of them had bad pathologic report. But you all know Mariette in Egypt, but we have another Mariette in France who was unfortunately a famous surgeon specialized in esophageal surgery. And he was at the head of a big database on esophageal cancer. So we decided to compare patients that were treated by cytoreductive surgery only and by patients treated with cytoreductive surgery combined with hyperthermic intraperitoneal chemotherapy. And we were able to compare 180 patients to approximately 100 patients treated by cytoreductive surgery alone. By doing a propensity analysis, we make the two groups really comparable, and the results of our study will be published in the next week in the Journal of Clinical Oncology. As you can see, we were able to adjust the groups and to make them comparable with this statistical technique for age, for neoadjuvant chemotherapy. The tumor had exactly the same stage, and you can see that most of them were poor prognostic tumor with a lot of poorly differentiated tumor and a lot of patients with major lymph node involvement. All were treated with a curative intent with a complete or subcomplete cytoreductive surgery, and there were no difference between the two groups. The only factor for which we were not able to make the two groups comparable were, unfortunately, the extent of the disease evaluated by the peritoneal cancer index. But you can see that the median PCI was higher in the group of patients treated by cytoreductive surgery and IPEC, and it was only 2 in the group treated by cytoreductive surgery alone. Despite this bad prognostic factor in defavor on the IPEC group, we found median survival and disease-free survival that was significantly better in the group treated with cytoreductive surgery and IPEC. Regarding the postoperative complication, IPEC did not increase the mortality and the morbidity rate, and most of the IPEC performed was IPEC performed for 90 minutes using cisplatinum or mitomycin C. So, in selected patients with very localized and limited peritoneal metastasis from gastric cancer, IPEC combined with cytoreductive surgery may increase overall survival and disease-free survival. But this not concern every patient, so we have to select properly this kind of patients. How to select them? First, you should be able to realize a complete cytoreductive surgery, and there is no place for this treatment when you have to let some millimeter disease. The extent of the disease is also very important, and you can see that no patients were alive at 2 years with a PCI more than 13, and no patient alive at 1 year when the PCI was more than 18. So the best indication for this kind of treatment is low PCI, and PCI maybe not more than 10 or 6. The problem is that this PCI is often not visible on morphologic exam, on CT scan, on PET-CT and MRI. So what should we do? We should perform, in every case of advanced gastric cancer, a laparoscopy to detect the limited carcinomatosis that are considered as a good indication. And sometimes we will detect also diffuse carcinomatosis with micronodular involvement that are not visible on the morphologic exam. It will allow us to adapt as well as possible the therapeutic management. Some particularities of this laparoscopy, especially for poorly differentiated tumor and signature cell tumor, this is that you should do a monotrocar access in order to exteriorize the small bowel and to make some palpation of this disease that may involve the mesenteric part of the small bowel, and that is often not visible on a regular laparoscopy, and that make the patient not amenable to complete cytoreductive surgery. You will, like that, avoid open and closed procedure. What about now signature cell pathology? You all know that this pathology is had a bad prognostic factor with a lot of peritoneal metastasis, a lot of lymph node involvement, and a lot of peritoneal recurrence. We looked into our database the influence of this pathology, and we find again that this kind of tumor has a different clinical presentation than non-signaturing cell tumor. More female and less positive HER2 statement. Most of them were associated with lanitis. More extensive disease also during the diagnosis with a more PN3 tumor with a more positive peritoneal cytology. And we confirm also, despite equivalent therapeutic management in both pathology, that the survival was poorer in the group of patients with signature cells cancer. But when we looked at the effect of IPEC in both groups, we found again that IPEC was an independent prognostic factor for overall survival, even in case of presence of signature cells. And when you look now at the median survival that we obtained with patients without any signature cell, without this poor pathologic report, you can see that the median survival was not reached. So, poorly differentiated tumor and independent of signature cells, cancer cells, should not be a contraindication for this kind of ambitious but aggressive therapeutic approach. Now, to finish, the influence of lymph node. You all know the influence of the degree of lymph node involvement in the surgery of gastric cancer without peritoneal carcinomatosis. So we decided to look at the influence of this lymph node status in case of peritoneal metastasis. And we found that N1 and N2 status had no influence on the prognostic, but N3 status had influence on overall survival. So now to finish, what could be the place of IPEC in the preventive and in the prophylactic treatment of gastric cancer? Because peritoneal recurrence is the most important problem in the recurrence of gastric cancer. And we know what are the cancers that will have an high risk of peritoneal recurrence. They are clearly identified. And once more, the meta-analysis showed that the use of intraperitoneal chemotherapy in case of absence of peritoneal metastasis may increase the prognosis of patients. But the problem is that this meta-analysis included a lot of Asiatic patients. And you all know the difference between Asiatic patients and between patients treated in Western countries. This is the reason why we decided in France and in Europe to conduct this kind of randomized trial. All patients at risk of peritoneal recurrence, but without any peritoneal metastasis, with a systematic laparoscopy performed during the preoperative workup, were randomized between curative gastrectomy and curative gastrectomy combined with an IPEC using oxaliplatin with low dose. The only thing that I can tell you for the moment is that IPEC with low dose of oxaliplatin did not increase the mortality rate and did not increase the morbidity rate following the 200 first inclusion. The other thing that is very important also is that despite the fact that we performed a systematic laparoscopy in the preoperative workup to include these patients, at the time of the curative gastrectomy, 16% of patients had peritoneal metastasis and were excluded from the randomization. This is particular, these findings was particular for patients with seed nectaring cells or independent cancer cells. So my conclusion would be that cytoreductive surgery and IPEC should be considered for some patients with gastric peritoneal metastasis as a curative approach. This is possible to cure some of the patients, but they should be strictly selected. They should be treated by complete cytoreductive surgery. They should have a very limited disease, and to detect them, the laparoscopy is very important to schedule at the initial diagnosis systematically in front of every advanced cancer, gastric cancer. And prophylactic IPEC should confirm its potential benefits, especially in Western countries. So we did many years to demonstrate in gastric peritoneal metastasis, but in other peritoneal surface malignancy, that we are able today to cure some selected patients. I hope that in the future we will be able to demonstrate that we are able to prevent a lot of this kind of poor prognosis recurrence. Thank you for your attention.
Thank you very much, Dr. Oliver, for this nice presentation. وفي نهاية اللقاء لا يسعنا إلا نتقدم بخالص الشكر لكل الإخوة الحضور، the chairpersons, the speakers، ونتمنى إن احنا كلنا استفدنا من هذا التبادل العلمي، ونتمنى أن نراكم على خير في اللقاءات القادمة. والغدا مستنيكم بقى على حسن الحكاية.